Hello everyone, this is Pei Zhongli again. Welcome to the class. Today we're going to study some mental disorders in childhood. Let me close my camera so we have a better sound quality. I'm going to share my screen. There are some very prominent mental disorders that occur in childhood. There are some prominent mental disorders that occur in childhood and even in infancy. First of all, let's look at the classification of mental disorders. Mental disorders come in varieties, and broadly speaking, they can be categorized into two broad types. One type is called externalizing disorders. Externalizing means, the behaviors, the negative behaviors, negative emotions, and negative thoughts are directed to other people, towards the outside world. The typical externalizing disorders would include hyperactivity, impulsiveness, aggressiveness, non-compliance. These are some of the common symptoms or common problems of externalizing disorders. It would also include aggressiveness, addiction to drugs, stealing things, theft, vandalism. Basically, you bother other people. These people bother others, and they are disruptive. They disrupt other people's lives and work, and they cause problems for other people. In childhood, some of the common externalizing disorders include attention deficit hyperactivity disorder, also known as ADHD, conduct disorder, and oppositional defiant disorder. Externalizing disorders are more common in boys than girls. A second type of mental disorders include internalizing disorders. These disorders usually involve problem behaviors directed towards oneself. Basically, the person is miserable, the person is torturing him or herself, the person sometimes even hurt or harm him or herself. In extreme cases, the person even commits suicide. These internalizing disorders include depression, anxiety, social withdrawal. In childhood, internalizing disorders mainly involve anxiety and mood disorders. Mood disorders, the largest category of mood disorders is depression. These two broad types, externalizing disorders and internalizing disorders, are very useful ways of thinking about mental problems, behavior problems. We're going to cover some prominent types of mental disorders in childhood. These disorders attract a lot of attention. We encounter these topics in the media and even in everyday conversation. People talk about them. People are concerned about them. One type of mental disorder that is quite prominent in childhood is ADHD, attention deficit hyperactivity disorder. This condition involves two broad types of symptoms or problems. One broad type of problems or symptoms is distractibility. The kids are really distractible. They have difficulty focusing. They cannot focus their attention for a long time. And they have difficulty concentrating. They often make careless mistakes, or when you watch them doing things, they seem to be very careless. For example, a child, 7-year-old, 8-year-old, is trying to take a shower. He's washing his hair and he's squeezing the shampoo. In most normal kids, kids at this age will be able to control the movement of squeezing shampoo. You get some shampoo on your palm, and then you rub it into your hair, and you wash your hair. But an ADHD kid may pour out half a bottle of shampoo, spill the shampoo all over the bathtub, and not able to really carry out the seemingly simple task of applying shampoo in a hair wash. This is due to distractibility, carelessness. The child always seems to be in a rush, always really busy, always trying to attend to different things. And they cannot follow instructions. It's really difficult to teach kids with ADHD to do a particular task, like playing a game. They have no patience. Their mind is wandering all over the places. And some kids have a lot of daydreaming in their mind. They would have a problem in listening to the teacher in class. They cannot focus on the lecture. Well, even when they're sitting still, even when they're not moving, even when they are sitting in their seats, their mind would be wandering, thinking about things irrelevant to the lecture, to the class. Most of the times, daydreaming. And they are forgetful. They forget to do their homework. They forget to do their household chores. They cannot remember instructions. These symptoms may persist into adulthood. Sometimes even in adults, people with ADHD still have a problem concentrating, focusing. They would have a difficulty learning things, studying, and have difficulty following instructions at work. And a wandering mind, wandering like a daydreaming, drifting mind causes a lot of distress. They want to focus, they want to concentrate, but they cannot seem to control their mind. Their mind seem to have its own life. The mind does whatever it wants to do. That's attention deficit. Hyperactivity. Hyperactivity is more common in kids than in adult ADHD patients. Hyperactivity means the kid has excessive activity. The kid is always moving, fidgeting. That's a movement of the hands, arms. They cannot seem to hold their hands, put their hands in their lap for any sustained period of time. Their hands are always moving, but not doing anything on purpose. Squirming, their facial expression, their facial muscles move quite a lot, like they're making faces. Running around, when inappropriate. For example, when they are in the middle of a class, when all the students are listening to the lecture in the middle of a class, a kid with ADHD might stand up and run around the classroom and even run out. Very difficult to discipline. And sometimes the kid talks too much, unable to stop. These are symptoms of hyperactivity. Of course, when you talk about problems like hyperactivity and lack of attention, you're also talking about social expectations. Society have expectations for appropriate behavior for children at a certain age. School-age children are supposed or are expected to sit still in the classroom during the class time and be able to focus attention on the teacher, on the lecture, on the class activities. So this is an expectation from the school, from the teachers, and from your peers, from other students. If a student, if a child, a school-age child cannot do this, he or she is considered to have a problem. He violates the expectation of the society for children of this age. And the excessive activity, hyperactivity, and distractibility might cause problems in peer relations. A child with ADHD is disruptive. It's not a good conversation partner, it's not a good playmate, and it's not a good classmate to have around, because he or she has a difficulty controlling his or her behavior. That might cause peer interaction problems. Maybe the kid will have a difficulty of establishing friendship, or maybe the kid might be bullied, might be isolated, causing a lot of social relation problems. These are the main symptoms of ADHD in children. Children with ADHD are slightly different from each other. They can be grouped into three categories, or three specifiers or subtypes according to the DSM, the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association. One subtype of ADHD is predominantly inattentive. These kids, they have a less severe hyperactivity problem. Their main problem is inattentive, unable to focus, attention problems, attention deficit. Another subtype of ADHD is predominantly hyperactive and impulsive. This case, the main problem for them is impulse control. They do whatever they want to. They do whatever it occurs to them. And it's difficult for them to self-discipline, to follow rules, to follow structured instructions, like in the classroom, in a play activity, in a game. And a third subtype is combined. These kids have both hyperactivity problems and inattention, attention deficit. The majority of cases of ADHD are of the combined type, with both inattention, attention deficit, and hyperactivity and impulsiveness. When we covered biological psychology, we talked about brain structure, the different brain areas, and we talked about the functions of different brain areas. If you think about the brain, especially the cortex, the cerebral cortex, which part of the cerebral cortex seems to be responsible for focusing attention, for regulating your behavior, for having plans and carrying out plans, follow instructions? It is a frontal lobe, especially the prefrontal cortex. This area is very much involved in planning, in goal-directed actions, in getting a task done, completing your homework assignments, planning your day, and also in controlling impulses. The frontal lobe is an executive branch of the brain. It is responsible for making plans, for reasoning, for making judgments, and making decisions. It is involved in forecasting or predicting the consequences of particular behaviors. Well, if I stand up in the middle of the class and then run around, what will happen? The teacher will be upset. My fellow students will laugh at me. I will be the laughing stock of the class. That's not good. So I'm not going to do that. These functions, these reasoning, judgment, and decision-making functions are very much related with frontal lobe functions. Kids or adults with compromised frontal lobe functions tend to have attention deficit hyperactivity problems. So frontal lobe, especially the prefrontal cortex, is very much involved in ADHD. Etiology. How does a disorder arise and develop? What are the causes of attention deficit and hyperactivity disorders? There are some genetic factors, but we don't know. Well, the genetic factors are poorly understood. We cannot pinpoint particular gene or particular genes or combination of genes that will lead to ADHD. The information about the genetic factors influencing ADHD come from adoption studies and twin studies. Psychologists have estimated that 70 to 80% of the variability in ADHD is due to genetics, heritability. And we have some rudimentary ideas about genes. 2 dopamine genes are implicated. The results are far from conclusive, but there's some suggestive or promising finding that genes that encode dopamine information might be implicated in ADHD. And there are also some related findings in brain structure and brain functioning. For example, some research report that in ADHD children, the brain areas, the area of the brain that uses dopamine as neurotransmitter, are smaller in ADHD children compared to normal children. And there's a very promising finding that ADHD children have compromised functioning in the frontal lobe, which we just talked in the last slide. When we are looking for causes or influences, factors influencing a particular mental disorder, like ADHD, we look for nature. We look for biological, genetic reasons, and we also look for nurture. We look for information in the environment, factors in the environment that might contribute to the development of the illness. Environmental factors include prenatal and perinatal factors, that is, factors before the baby is born and immediately after the baby is born. Low birth weight seems to have a strong relation with ADHD. However, babies with normal birth rate can also develop ADHD. So this is not a causal conclusion. This is just a correlation. And some kids with low birth rates don't develop ADHD. Not all kids with low birth weight eventually develop ADHD. Another prenatal, perinatal factor is maternal tobacco use, alcohol use. We talked about the kind of poison materials that can influence the fetus when the mother is pregnant. Tobacco and alcohol are among the strongest, most prominent factors influencing fetus development. Environmental toxins, we mentioned nicotine, maternal smoking, and some people say food additives might have something to do with ADHD, but there is very limited evidence. Does sugar lead to ADHD? There's no evidence. Another aspect of environmental influence is, of course, from the parents. The parent-child relations might have something to do with ADHD. This is at least a theory. It is a possibility. Some research report that the parenting style, the authoritarian parenting style, might have something to do with ADHD in children. Those parents who give more commands and give less explanations and give more negative instructions, feedbacks, are more likely to raise children with ADHD. This is also a correlation research. And there's the evidence is not really strong. Some family factors, family environment, family atmosphere, parenting style, this all might contribute to ADHD, but we cannot say family factors or parenting factors cause ADHD. They might contribute to maintaining ADHD symptoms or behavior, but we cannot say ADHD is caused by a particular parenting style or a particular family factor. The strongest evidence point to frontal lobe, brain function. Right now, the best information we have about ADHD is that their frontal lobe is under-aroused. Frontal lobe activity is kind of weak in ADHD children and in ADHD adults. When the frontal lobe activity is weak, when the frontal lobe is not doing its job as executive system of the whole brain, the brain is like in a chaos. Impulse is not properly controlled. Attention is not properly regulated. Hyperactivity results. You have a very impulsive, very disruptive, very difficult discipline, very difficult to focus and focus individual. The current treatment for ADHD include medication that stimulate frontal lobe activity. This medication are called stimulants. They stimulate frontal lobe activity. So when the frontal lobe is more aroused, works harder, the person is able to focus better and is able to impose some constraints on their impulses. If we use a psychoanalysis concepts, the medication, the frontal lobe stimulation will improve their ego strength. They will have a stronger ego, be more aware of the expectations of other people, of the environment, and be more capable of controlling their instincts, their impulses, their id. Remember when we talk about the psychoanalysis, we mentioned the concept of id, which is unconscious drive, unconscious instinct. And this unconscious instinct seek immediate gratification, cannot wait at all. If I want to eat ice cream, I want it now, right now, at this moment. I cannot wait. If I want to speak, I just open my mouth and speak. And if I want to go outside and play right now, I stand up from the middle of the class and walk out of the classroom. I don't care. I cannot care. I'm unaware of that I need to sit still in the class. So stimulating the frontal lobe functions will help the kids better regulate themselves and better able to focus their attention. Sometimes medication stimulants are combined with behavioral treatment, behavioral therapy. Well, behavioral therapy helps, but not by a whole lot. Medication plus behavior treatment works slightly better than medication alone. The behavior therapy or behavior training, behavior management styles mostly help the kids improve social skills, improve their skills in communicating their needs to other people, and have a better relations with others, with their peers, with the teacher. But for the control of attention and impulses, hyperactivity, the medication is really the way to go. That's ADHD. ADHD may be considered a special need condition. Children with ADHD definitely need some special attention in the classroom, in everyday life. They need some assistance. Their parents need to be trained about the characteristics of their children, the needs, the special needs of their children, and there might be some need for accommodation for the needs of ADHD children in the classroom. For example, the assignments should be shorter. These kids have a very short attention span. Before they completely overcome their attention deficit, they need to be given tasks that are brief. And also, they need to be given immediate feedback. If they do something right, give them positive feedback right away. If they are doing something wrong, tell them on the spot. Don't wait. This will help them correct their behavior shape their behavior to be more compatible with the environment, with the environmental expectations. ADHD is one type of mental health problems or mental disorders in childhood. Another kind of a mental disorder in childhood is called conduct disorder. It bears some similarity with ADHD, but it is quite different. Conduct disorder, this concept conveys social expectations. These kids violate social norms. These kids engage in behavior that are considered out of normal, even delinquent, even illegal. They show aggression. They attack other people, they hurt other people, and they show cruelty towards other people or animals. They damage properties, vandalism, lying and stealing is very prominent in conduct disorders. And they are all, most of these kids are very careless, vicious. They don't have a lot of sympathy or compassion for other people. They seem to be really cold-hearted. In some extreme cases, they even kill people. Every time I talk about conduct disorder, I remember the Columbine shooting. Columbine High School is in the US state of Colorado. 3 high school seniors, right just before their graduation from a high school, they took guns. You can see they took some sophisticated weapons and went back to their high school and just randomly shot people. They killed 13 people and injured many more, and then they killed themselves. This is very difficult to understand situation. Every time you have a situation, some people really showing some really weird, bizarre behavior, which is deviant, which is abnormal, you think about some kind of a pathology. This behavior is definitely outside the normal range. Definitely, this is mental disorder. So, of course, these people, they don't have a formal diagnosis, but to me, their behavior looks like some extreme form of conduct behavior. They are aggressive, they are cruel, they kill people, they damage properties, they lied, they stole, and they vandalized. And they are very careless. Oftentimes, conduct disorder is associated with drugs, substance abuse. And then many of these people with conduct disorder also suffer from anxiety and depression. We don't know which one comes first. Did conduct disorder appear before depression and anxiety, or did it appear after anxiety and depression? It's really not clear. How many people, what percentage of kids have conduct disorders? It varies from group to group. Different groups from different areas and even different social economic background have different prevalence. Of course, poor neighborhoods tend to have a high prevalence. People kids living in poverty and in harsh environments tend to show a stronger tendency for conduct disorder. And boys tend to show stronger tendency for conduct disorder than girls. In some neighborhoods, in some groups, among boys, as high as 16% of the kids have some form of conduct disorder. That's quite a high numbers, quite a lot. Conduct disorders have two broad types. One type is lasting for a long lifetime. It's called a life course persistent pattern of antisocial behavior. These are delinquent kids with conduct behaviors in childhood would grow up to become antisocial adults. They become sociopathies. Sociopaths and antisocial personality are more common in boys than in girls. That's one type of conduct disorder. Another type of conduct disorder is limited to adolescence. These kids show some antisocial, aggressive behavior when they are adolescents, but they outgrow it. When they become adults, their problems seem to go away. The explanation is that in this adolescence, their physical maturity is advanced. They are powerful, they have powerful muscles, they are very energetic, but their psychological development is not catching up. The gap between physical maturity and mental immaturity lead to problem behavior. The life course persistent type of conduct disorder is associated with a very distinct group. These people with lifelong antisocial behaviors, with these psychopathies, they tend to have academic problems, not good students. They have lower IQ, neuropsychological deficits, and many of them have ADHD, and many of them are in the low social economic status groups. Of course, a family problem is very common among conduct disorder children and adults. What factors cause conduct disorder? This, of course, is a very complex issue, complex problems. Right now, most psychologists believe a combination of social factors, environments like poverty, and psychological factors like some personality flaws, as well as some biological factors, influence the development of conduct disorder. Of course, there are many details involved in this biopsychosocial model of causation. These styles are not all very clear. Some social factors do have a strong influence on conduct disorder. For example, poverty and the kind of inner city environment in many large cities in the US, they contribute to conduct disorders, like a gang. Many places with gangs, and kids get affiliated with deviant peers, peer influence, peer pressure, and also rejection, social rejection by the so-called mainstream society might also lead to conduct disorder. Being marginalized is a strong factor in developing conduct disorder. The treatment of a conduct disorder is quite difficult. I wouldn't call it a treatment. this is better called management. How do we manage conduct disorder? Family intervention, social interventions are very important. Nowadays, from a society point of view, multi-systematic treatment or management of conduct disorder might be effective. It would include community efforts and social agencies, institutions, like child care institutions, schools, neighborhoods, peers, family. All these layers of social influences are also involved in the development of conduct disorder and also involved in the correction or treatment of conduct disorder. Of course, it's very difficult to treat or manage conduct disorder outside of the legal system. Most of these kids eventually end up having trouble with the law. But in the community, sometimes it's difficult to manage their behavior because they have problems at different levels. They usually live in an environment that don't have a lot of resources, like social resources, good schools, safe neighborhoods, etc. They don't have access to normal peers, good peers, get a lot of negative influence from their peers, and their family are oftentimes dysfunctional. So in the community, it's a lot of challenge to manage conduct disorder. Another group of mental disorders in children and adolescents are depression. These are internalizing disorders. Depression and anxiety sometimes co-occur or happen together with ADHD and conduct disorder. And of course, they can also happen without ADHD and conduct disorder. Anxiety and depression often go hand in hand. Many people with depression have anxiety, and many people with anxiety problems also have depression. Research shows there are some differences between depression and anxiety. Depression is mostly have a lot of negative affect, negative feelings, feeling sad, feeling worthless, feeling miserable. General sense of distress is very prominent in depression. And depressed people also have a low positive affect. This means depressed people have a poor ability to experience pleasure. There's no fun in their life. They find only misery in their life. They don't get excited. They are really difficult to get happy, to feel happiness, to feel enjoyment, to feel sense of being calm and content. It's difficult for depressed people. No fun, all misery. But for anxiety disorders, they also have a lot of a negative affect. Being anxious is very uncomfortable. It's not fun. It's very miserable. It's very painful to be anxious. But they don't, well, some research show that they have some positive affect. They are able to experience pleasure, contentment, happiness from time to time. But more recent research calls this finding into question. More recent research shows that even with anxiety disorders, the ability to feel comfortable, to feel content and relax also quite low. So people with anxiety disorders also have a very few fun feelings or positive feelings. But there's one difference between anxiety and depression that is quite prominent: the level of arousal. In most anxiety disorders, the level of arousal is quite high. When you are fearful, when you are panicking, your heart rate increases, your blood pressure goes up, and you feel fidgeting. This is a high arousal state. On the other hand, in depression, most people feel depressed. Most people feel fatigue, lethargy. They don't have a lot of energy. Depression is a low energy, low arousal state. What factors cause or lead to depression and anxiety in children and adolescents? Genetic factors play a big role. Depression is very heritable. Parents with depression have a high likelihood of bringing up children with depression and also anxiety. Genetic factors play a part, and also harsh environment, early adversity, so even early trauma, bad experiences, setbacks, poverty, negative life events, in extreme cases, death of parents, being orphaned, being abandoned, being mistreated, neglected by the parents would also lead to depression. There are also cognitive factors. People with depression have a particular way of thinking, very negative way of thinking about their experiences, thinking about the world in general. And there's some evidence showing that depressed people have a particular attributional style, which means the way they experience their experiences. They tend to experience their failures as pervasive. So if they suffer a small setback, for example, if they didn't do well on a particular test, they tend to blow it up out of proportion. They tend to overgeneralize the situation. So if you fail one test, you see yourself as a total failure, as a total loser. You see your entire life as worthless. And when depressed people encounter some difficulties or setbacks, they tend to think it's going to last forever. They will never recover. Things will never change for the better. And depressed people also tend to make internal attributions, blame themselves for negative outcomes. When they suffer a rejection, for example, when they try to join a social group and the social group didn't accept him or her, they feel rejected and they blame it on themselves. They feel I'm unworthy, I'm unlovable, I don't deserve to be treated well, etc. Both environmental and biological and psychological factors can lead to depression. Treating depression basically is a two approaches: medication and psychotherapy. Medication mostly involve balancing serotonin. There's some research showing that people's depression don't have enough activity in serotonin binding with the serotonin receptors. So taking medication that contain serotonin reuptake blockers can help ease depression. Of course, a medication always have some side effects we need to be careful about. Another alternative to a medication is a psychotherapy. Cognitive behavioral therapy may help people with depression, including children and adolescents. Anxiety. Anxiety is also quite common in children and adolescents. We tend to think that children are carefree, this is best time in your life, you are well protected, but kids also have their concerns, worries, and fears. Fears and worries are quite common in childhood. Anxiety disorders involve mostly fear and worry and nervousness, tenseness, and it interferes with social functioning. It interferes with school. Some kids are so anxious and so fearful of going to school that they don't want to go to school. And some people are so fearful of the social interaction, they don't have a social life. Most childhood fears tend to disappear when people grow up. But those people who are anxious as adults tend to have a history of childhood anxiety. About 3% to 5% of children and adolescents have anxiety disorders. In children, there are particular types of anxiety disorders, very special to children, separation anxiety. This is anxiety when the child has to separate from the parent, mostly from the mother. Social anxiety is another type. Kids with social anxiety are shy, extremely shy and quiet. Some of them, they don't speak in front of strangers at all. About 1% of children and adolescents have social anxiety disorder. Etiology, well, how do kids develop anxiety disorders? There's a strong genetic factor. It's very heritable. Genes do influence people's anxiety levels. Temperament, some kids are born introverted, more shy, more inhibited. Some kids are naturally more outgoing. And at the psychological level, shy kids with a lot of fear, worries, and anxiety, they tend to overestimate danger. And they tend to underestimate their coping ability. They don't have a lot of self-efficacy and confidence. So they think that the world is pretty dangerous. And they have poor social skills. Because of poor social skills, they don't want to interact with other people. They have a fear of a rejection. There's an estimate that genetics account for about 30 to 50% of the variability in anxiety disorders. On the other hand, parenting styles play a smaller role in anxiety disorders. So anxiety disorder is very much related with genes, and at the brain level, at the nervous system level, anxiety is related with the amygdala. Remember the brain structure amygdala, which is responsible for producing fight or flight responses. So there's some research showing that kids with anxiety disorders, their amygdala tend to overact, tend to become overactive when they are stressed, when they encounter some threatening situation. Treating anxiety disorders in childhood and adolescence, behavior therapy is very commonly used, and of course medication. Medicine is also very commonly used. Medication mainly reduces over-arousal of the nervous system and reduces over-arousal of the sympathetic nervous system. So the entire nervous system calms down a little bit to reduce the overall anxiety. Behavior therapy and cognitive behavior therapy involve exposure. Exposing the child to the feared situation. For example, if the child is fearful of public speaking, and then the therapist should help the person to get used to public speaking and developing appropriate skills for coping with kind of a situation. Modeling. So while at the beginning, it's very difficult for a child to develop the right skills, the therapist might do some modeling, provide a role model, show him how to do it, and encourage him to copy the appropriate behavior. And then with a skill training and practice, hopefully the child will master the appropriate behavior for coping with the situation, and then overcome the fear. Family is encouraged to be part of the treatment. Relapse prevention is very important because the fear tends to. The next type of mental disorders in the childhood we're going to discuss is autism spectrum disorders. These problems have a common feature. The kids have difficulties in establishing and maintaining relations with the outside world, with other people. Humans are social animals. We are different from reptiles and some asocial animals. Some reptiles, for example, snakes, they spend most of their lives individually. A snake would live mostly by itself. It may come into social contact with other snakes only when they're mating. They don't even fight with each other that much. They are loners. But humans live in groups. We rely on our relations with other people for almost everything. If a person cannot have a relation or proper relation with other people, that's going to be a very serious impairment. Individuals with autism spectrum disorder, have a profound difficulty in associating, in relating to other people. The word autism means self-centered or self-oriented. These people live in a bubble. These people live in their own world. The DSM lists the key features or key problems, key impairments, the key dysfunctions of autism. The most prominent impairment is problems with the social world. This condition is usually diagnosed when the child is 2 years, 3 years, or 4 years old, when they should be developing social skills, when they should be interested in the outside world, at least interested in their parents. All normal children have an attachment to their parents. They follow their parents, they want their parents' attention, and they learn to speak, they learn to communicate with other people. But children with autism, they show no interest in other people. They're not even interested in relating to their parents. They don't approach others, and they don't treat other people like animals. They treat other people, including their parents, like furniture, like physical objects, like rocks. They don't talk, and they don't perceive emotions in other people. One really prominent feature in people with autism is that they don't look into your eyes. They don't have eye contact with other people. Even when they're talking, even when they're high functioning and they talk to other people, they don't have eye contact. They usually look at other people's mouths. So this way they have difficulty in perceiving other people's emotions and have a meaningful emotional exchange with other people. Some psychologists believe that people with autism have an impairment in the theory of mind. The theory of mind is a concept in developmental psychology. It means that as children, when we grow up, we gradually grasp the concept that other people have wishes, they have desires, they have their own ideas, and they perceive things. They have their own perception. We treat other people as mental beings. Oh, they have minds. They have minds just like I have minds. They have feelings, and they may see things. They know stuff. And kids are interested in what other people know, what other people think, how other people feel. This is a very basic ability for relating to other people. But many researchers believe that people with autism lack this kind of development. They have impairment in treating other people as mental beings, as psychological beings. That's why they have such a profound difficulty in relating with other people. Most people with autism have communication deficits. In severe cases, they don't speak. They don't acquire a native language. They have problems developing language skills. And sometimes they speak in an abnormal way. They don't have some high functioning autism, people with autism, they can articulate words, they can speak words, but conversation is difficult for them. They don't have a back and forth two-way communication with other people. Sometimes they display a phenomenon called echolalia. Echolalia means echoing. They repeat what other people say. So, for example, if you ask a person with autism, have you had dinner yet? And he would not be able to answer you. Instead, he would just repeat you like a parrot. He would throw the question back to you. Have you eaten dinner yet? Have you had dinner yet? Word for word. And then if you ask him or her, what did you have for dinner? The person may repeat your question. What did you have for dinner? It's very difficult to really kind of communicate in a two-way conversation. Sometimes they have pronoun reversals. They refer to themselves as he or she rather than I or me. Some people and children with autism have stereotyped behaviors or acts, ritualistic acts, really looks really sensitive, senseless, no purpose. It's not play, it's not instrumental actions, just repetitive movements. Some children with autism even have self-harming behaviors, like some autistic children bang their hands against the wall. It could be really dangerous for them. And some autistic children try to push their hands into their mouth, down their throat, and that's really self-harming. Many children with autism, they have a strong need for routine. Everything must happen in the same order every time. And sometimes they're obsessed with objects. Some autistic kids are obsessed with keys, rocks, can't take it away from them. They cling to these objects. Toothpicks. But they're not interested in other people, not interested in playing with other kids, not interested in talking to other people. Most autistic people have intellectual disabilities. It is quite common for children with autism to have a low IQ scores below 70. Below 70 is mentally challenged. It can be categorized as intellectually disabled. The prevalence of autism is about 1 in every 110 children. It's like about 1%. And autism is really found in all socioeconomic status groups. All ethnic groups have children with autism, and all racial groups have children with autism. This shows that environmental factors play a minor role. It's mostly genetic or biological. Undiagnosis of autism is quite stable. It means that these children don't improve that much. Autistic children tend to have the same problems when they grow up. Many of them cannot live independently. They have to be taken care of. They have to be supervised. They have to live in an assisted environment. Some some children with autism do improve, although most of them, especially the severe cases, they don't improve that much. There's a class or group of autistic children who are high functioning. And these people can speak. They acquire language before 6 years of age. And these people have much better outcomes. Some of them live independently. Some of them even can have jobs, start their own family, and be quite successful and productive in their adulthood. These are the high-functioning autistic children. What causes autism? What kind of factors lead some children to develop autism spectrum disorders? In the past, in the 1950s and even before that, psychologists used to believe it was parenting. It was a parent to blame. In those days, psychologists used to believe that cold parenting, especially cold mothers, lead children to become autistic. But later on, more research shows that this is not the case. Genetic factors account for about 80% of the variability in autism-related disorders. Twin studies support the other genetic theory. In identical twins, the concordance rate is between 47 to 90%. In other words, among identical twins, if one twin is autistic, has autism spectrum disorder, there's almost a 50 to 90% chance that the other twin will have the same problems. Identical twins share 100% of genetic makeup. They're basically clones of each other. On the other hand, the concordance rate between fraternal twins, non-identical twins, are much lower. It's between 0 to 20%, less than 20%. In other words, in fraternal twins, who are just like regular brothers and sisters sharing 50% of their genetic makeup, if one twin has autism, the other twin only has less than 20% opportunity to have the same disorder. This research shows that the genetic factors play a big role in developing autism. But exactly which genes, what are the genes responsible for developing autism? The mechanism is not very well understood. Researchers have found some biological characteristics of people with autism. The brain size seems to be a little bit different from normal people. These children have normal brain size at birth, but when they become adults, their brain size seems to be larger than normal. Psychologists and doctors speculate that when the children are developing in normal development, we prune the connections. We prune the connections which are useless. So, as we grow up to adulthood, we have less and less connections between neurons. And in autistic children and autistic adults, these overgrown connections are among different neurons have not been pruned properly, so they are overgrown. How do we manage children with autism, autistic spectrum disorder? There's no cure. There's no proven cure for this kind of disorders. The best we can do is to manage the behavior, manage the problems. Early intervention is very important. Early intervention, identifying the problem, the earlier, the better. Usually, the children are diagnosed when they are 3 years old, 4 years old. And then if you can diagnose the children before that, like 2 years old, that's even better. The kind of intervention mostly involve operant conditioning. Operant conditioning means that you reward desirable behaviors. You reward eye contact. You reward proper conversation. And you reward meaningful behavior. And you don't reward undesirable behavior like self-harm, banging your head against a wall, obsessive repetitive behaviors, disruptive behaviors. Those are discouraged. Parents play a big role in the management of autistic children and in their treatment. Having a child with autistic spectrum disorder is a lot of stress, a big burden on the parents. So parents need to receive a lot of training, a lot of education on the disease, and also on how to manage the behavior of autistic kids. Sometimes medications are used. Medications are used mostly to reduce some disturbing symptoms. For example, some autistic kids have aggressive behavior. Aggression may be directed to other people or may be directed to themselves, self-harming behavior. But medication, the kind of medications we have really does not improve language or interpersonal relations. These are the most prominent mental disorders in childhood.